like to introduce our keynote presentation now. Associate Professor Michael Wright's a GP, health economist and health services researcher with the International Centre for Future Health Systems, I should say. Michael's research interests include evaluating the value of primary healthcare within broader health systems, the impact of primary care funding and policy on health outcomes. So when he's not doing that, Michael's also a practicing general practitioner and also currently national president of the RACGP, Royal Australian College of General Practitioners. I use too many acronyms. Susan said we love our jargon, we really do. Michael's currently the president and will be delivering our keynote presentation. So thanks very much, Michael.
Thanks, Ben. Got the clickers right. Hi, everyone. As Ben said, I'm Michael Wright. So I'm a GP in Sydney, health economist, president of the RACGP, and I'm previous president of Central and Eastern Sydney Primary Health Network, chair of the board for the PHN. So nice to see some familiar faces around the room, and as well an associate professor at the International Centre for Future Health Systems. What I'm going to do today is speak about some of my experiences with some of the work we've been doing at UNSW, but also some of my perspectives as a GP and trying to understand what's the direction of health system reform and how might community health navigators have a role in that. I'd also like to acknowledge that we're meeting on the land of the Gadigal people and pay my respects to elders past, present and emerging, and extend that respect to Aboriginal and Torres Strait Islander colleagues joining us in the room and online, and also recognise that's particularly important as we walk together through Reconciliation Week. So what I'm planning to cover today is firstly examine some of the current problems that the health system is facing, but obviously I'll do that from a general practice point of view, so perhaps a little bit of a different perspective from our previous speakers. Then I'll move on to highlight some of the potential solutions, and then particularly how community health navigators might fit into this reform agenda. So before I begin, I just thought I'd give a vignette just to show a pretty typical experience of someone trying to navigate Australia's health system. So Maria is a 61-year-old lady living in the inner western suburbs of Sydney. She's got type 2 diabetes, hypertension, coronary artery disease, and chronic depression. So she receives a disability support pension, but lives alone because her kids have moved interstate. And she really struggles to navigate the fragmented health system. So although she's eligible for a chronic disease management plan, her local GP, who still does bulk bill, is booked out for weeks and she can't get an appointment. And she's requiring long waits for the appointments, and because she can't access that plan, that makes it difficult for her to access allied health providers. Follow-ups with the diabetes educator at the hospital are irregular due to their limited availability, and she's yet to see a cardiologist despite having multiple appointments and multiple referrals made. Her mental health condition compounds these challenges. She's been referred to a psychologist through Medicare, but she can't find a bulk billing one, and she can't afford a private mental health care because it's just not sustainable on a single income. Depression impairs her motivation, also her ability to manage her physical health, making it harder for her to remember to take her medications, and also leading to missed appointments. She's had a couple of emergency department visits with very high glucose, and each time she's stabilised, discharged, but without a coordinated follow-up plan and without any communication received by her usual GP. And this results in a cycle of crisis without long-term management, and it's an all too familiar story. So unaffordable mental health care, overstretched primary care services, lack of awareness of services and poor coordination between them. So despite living in a very well-resourced city like we do here, the lack of integration and continuity of care makes Maria's health very vulnerable. Now, list of challenges as long as your arm. Now, Australia's not alone in facing multiple health system challenges. We've got an ageing population increasingly living with chronic diseases. Access to care is high, but it's decreasing, particularly for marginalised or disadvantaged people. The costs of care are increasing for individuals, but also the broader health system. We've also got increasing expectations of care, whether that's through the use of technology, but also patient demand, all of which further can increase cost. We've got a growing health workforce, but increasingly there are some blurring around the boundaries of scope of practice and responsibility, which can make it confusing for healthcare workers, but also for patients. And we definitely have ongoing inequity, which we've failed to manage, particularly for Aboriginal and Torres Strait Islander Australians, people living in rural and remote Australia, and people with socioeconomic disadvantage. But to top it all off, we have an increasingly complex health system, which is exacerbated by a dual funding health system. So as many of you know, Australia has a dual funded federally federated health system. So states and territories have the constitutional responsibility to fund hospitals, while the federal government has responsibility for providing out of hospital care. And so Medicare, which is our universal health system operating since 1984, covers all costs of public hospital care, but it subsidises community care, such as predominantly medical care, but including the care provided by GPs. But there can be out-of-pocket costs, and they can be significant. And you will have heard about people being bulk billed or having out-of-pocket costs. So in addition to Medicare and that dual funding, we also have around 40% of the population have private health insurance, which allows them access to private hospital health services, but also often with significant out-of-pocket costs. And then the small line down the bottom is we also have separate funding systems for disability, for war veterans, for aged care, and for social services. So all of that complexity is what we're trying to work in that system, those of us who are working in it, but also someone like Maria is trying to navigate through. I've got to do one slide for GPs. So look, we've got more than 7,000 general practices around the country, but the majority of them are small to medium enterprises and they're private businesses. We have nearly universal access to electronic records within our practice, but people are often surprised to hear that we've got very rudimentary communication. Like we can't communicate between practices, and there is no communication, well, very little communication between a practice and anywhere else, let alone the local pharmacy or the tertiary hospital in a suburb away. And that's one of the challenges we're dealing with. The majority of the funding comes through Medicare billings, through fee-for-service, which creates an incentive to get people in and see them, but it doesn't create an incentive to provide more preventative health or more longer-term care. And we also have things, patient out-of-pocket costs are increasing, and we also see some incentive programs which are providing more bundles of payment, what called the Workforce Incentive Program, and also the Practice Incentive Program, but at the moment they make up less than 10% of the funding that goes to a practice. And I'll touch on that because that's a potential way that we may be able to fund the work of community health navigators. So how does it all come together? There is an international study that comes out every couple of years, put together by the Commonwealth Fund, which produces a comparison of high-income countries. And in the most recent version, Australia comes out on top as the #1 health system overall, with very high health outcomes, very high equity, second in administrative efficiency. But if you look, there are a couple that we come down with. So in this analysis, access to care refers to both affordability and accessibility of health services, and we get 9 out of 10. Only the US is seen to be worse than us in that one. And then care processes relate to prevention, safety, and coordination. And you can see in that one, we're kind of middle of the road. So there is learning to be had. I won't touch long on this, but we do have major demographic and population pressures. So we've got a growing population, an ageing population, and more of the population are living with chronic health conditions like diabetes, asthma, epilepsy, depression, the conditions that Maria has. And close to 50% of adults over 45 have multiple conditions or are living with multimorbidity. And that means they've got complex care, they have multiple diseases, they have multiple treatments which often interact with each other. And a lot of this care is being provided in the community in primary care, but it's complex, it's time consuming, and the way that Medicare is structured, it doesn't acknowledge that complexity and make it harder for patients to be seen properly. We also know there's a major increase in the treatment and recognition of mental health conditions, and that's an important part. So 1 in 5 people had a mental health disorder in the previous year. Now, on the surface, access to primary care looks pretty good. So look, more than 22 Australians saw a GP in the last available statistics. In the same year, over 160 million visits. The visit rates increase as people get older, and the visit rates are slightly higher for women compared to men. And only 1.1% of people said they couldn't see a GP when they needed to. But if we dig a bit deeper into those figures, you can look at, this is data from the ABS from last year, which is look at, of the 18 million Australians who saw a GP in the last year, about 3 out of 10 now report delaying or not seeing a GP when they needed to. Now, some of this is because they couldn't get an appointment or they said it was too hard and they stopped, but importantly, an increasing number of people are not seeing a GP due to cost and they're reporting to put it off. So nearly 9% of people in the last data, and that's up from 4% back in 2017. And in addition to that, around 3 in 10 people say they waited longer than what they thought was acceptable to see a GP appointment. And the people with the most economic disadvantage, and also young people, were the people who were most likely to put off seeing a GP due to cost. And I suppose the point making here is that the percentages kind of override the numbers in that, it might only be 8.8%, but, over 150,000 adults said they couldn't see a GP when they needed to. Over 1 million people delayed seeing a GP due to cost, and that's more than doubled in the last decade. And many of these people are likely to be the people like Maria. Now, if we come to our health workforce, we know that the healthcare sector is the fastest growing part of the Australian workforce. And as I mentioned, as we've got growing expectations of care and also growing demand for care as we age, we're going to need more health providers. But our supply of health providers hasn't been keeping up with the demand for a number of years. So we've had a number of recent reviews which have looked at the supply and demand. I've just put some figures there from the report from Robin Crook, which was released in 2023, and that identified by the end of 2026, Australia's going to be short by 13,000 medical practitioners, 40,000 nurses, and over 25,000 allied health providers. And on top of that, so as well of having a sort of inadequate pipeline, for want of a better word, of health practitioners coming through for our needs, we know that GPs in particular are ageing, are retiring, and on average are working a bit less as they do more portfolio work. We also know that junior doctors are much less likely to choose a career in general practice than they were. So around 40 years ago, almost 50% of medical students went into general practice. Now it's about 1 in 7 choose to be a GP or a rural generalist. And the scary one on the side is nearly 1/3 of GPs say they're going to retire in the next 5 years. Not me. Look, I've just sort of come back to the challenges and that kind of just to bring us back to where they all are. And you can see that there is a lot of work that we are going to need to do. And there's a lot of issues to deal with, but we're not starting from ground zero. There have been a lot of government reviews over the last 20 or 30 years which have looked at how we might deal with a lot of these problems. And I'm just going to touch on the most recent one, which has been the Strengthening Medicare Task Force. So this has been the focus of serious discussion, and the current health minister actually was on this task force and oversaw this paper. And in this document, it describes a vision for the future of our health system, led by strong primary care along 4 main priorities. And it's useful to hear them because a lot of what the reform agenda that the health system is going through aligns with this. So 1, all Australians are supported to be healthy and well through access to equitable, affordable, person-centred primary care services, regardless of where they live, with financing that supports sustainable primary care and a system that's simple and easy to navigate. And this plan talks about different funding models beyond fee-for-service that would make this happen. There's also a lot of a focus on coordinated multidisciplinary teams of health professionals, and they need to work to their full scope of practice to provide high quality, person-centred continuity of care, including a focus on prevention and early intervention and primary care working with other parts of the health system and reducing fragmentation. We need data and digital technology to inform value-based care and to empower people to participate in their own healthcare. And finally, we need a primary care sector that's well supported to embrace organisational and cultural change, and consumers to be empowered to have a voice in the design of services, particularly for disadvantaged groups. So this does create sort of a bit of a roadmap for dealing with what I would say are some of the solutions that we've looked at previously, and a lot of these are already underway. We've been training more health professionals progressively over the last 30 years, as well as training our own doctors, nurses, allied health providers. We've also embraced international health practitioners and encouraged them to come to Australia. We can try to increase the efficiency of health professionals, and one of these is around this idea of working to the full scope of our practice so that the most clinically trained or the most appropriate person does the most cognitively demanding work, but that does rely on us working more in teams. We could talk about the overall efficiency of our health system, and technology will help that. Currently, we spend a bit under 10% of our GDP on the health system. That's a little bit above average for the OECD. But one of the ways we could improve our efficiency is by putting a greater focus on prevention, health promotion, keeping people well in the community, stopping them from needing to attend, frankly, more expensive hospitals, emergency departments, and tertiary care. But in order to do that, we've got to strengthen primary care or shift some of the care back into primary care. We can also try to reduce fragmentation or duplication, but that's a difficult thing in our dual-funded system when different systems don't communicate. And then there's also the opportunity to improve health literacy, self-management, and also a priority to improve communication, particularly clinical handover. And if I look at these last four, and probably even the efficiency of health professionals, these are all potential areas where community health navigators may be able to provide some assistance. So CHNs, so community health workers and community health navigators. Look, in the work that we've been doing at UNSW, we've been using the term community health navigators just to distinguish them from other community health workers. So we've got nurses who work in community health centres. So the term is about that. And it's also to highlight that this is a non-clinical role. It's supporting navigation to health and social care services and programs. So the CHW role, or CHR, it's not new. Its use in marginalised populations in the USA began in the early 1960s. And these workers are now in many countries working with community organisations, with health departments, in primary care, in clinics, hospitals, schools, churches. In Australia, we've had a long history of Aboriginal health workers, and they are sort of the best example of a community health navigator in Australia. But we've got other lay and peer workers, although they've often not been acknowledged as having a formal role in our health system. In essence, what community health navigators do is they establish strong connections with community members, understanding their unique needs and challenges. And what they do is they support people to navigate, act as a link between the community and the health system. They build relationships and trust between community and the health system. They can conduct outreach and education. They can provide health education, behavioural counselling, information and support, which is particularly important during care transitions, where they can help someone coming into hospital, coming out to hospital, needing an appointment with another provider. CHWs basically can help someone navigate the healthcare system, ensuring they receive the appropriate care they need and follow-up services. They also have the ability to advocate for their clients, so kind of identifying barriers for care that people working in particular silos might not recognise. And they ensure that their individual people working with them have access to the necessary resources and services. Particularly, they're really good at preventing the onset of disease and promoting overall health and well-being through highlighting the variable resources available to people. So lifestyle modification, but encouraging health screening, providing some health education, and as I said, lifestyle counselling. So in essence, they provide the bridge between the community and the healthcare system, working to improve health outcomes and reducing health disparities through a lot of strategies. As I said, they have a lot of different names, and there is a lot of overlap between these non-clinical roles. So the Aboriginal health workers are the most common in Australia, but we also have peer workers, link workers, outreach workers, care find. All of those people are similar under this umbrella, But as I said, their main distinction is they're not clinicians. And what do they do? So, well, by providing their range of services, better linking community members to the health system, there are multiple potential benefits, particularly enabling access to health services for people who might otherwise struggle, either due to financial reasons, language reasons, socioeconomic reasons. And by working in the community, CHNs are hoped to be able to better address the social determinants of health within the community, providing better access to preventative and primary care, and reduce the burden on the rest of the health system. Now, there's a growing evidence base about the benefits of CHW and CHNs, and you will have seen a number of posters before you came in, which is actually from a lot of our group at UNSW. And I'd just like to acknowledge Professor Mark Harris for your leadership, Mark, in growing this database, and Elizabeth for getting this work happening in Australia. And I'm just going to run through a little bit of the evidence about community health workers. So they do have an evidence, it is growing in terms of an improving cancer screening, improving the management of chronic diseases such as diabetes, hypertension, even in delivery of HIV care. And they've been particularly effective in improving maternal and child health outcomes and preventing undernutrition. And I know Professor Harris led a 2021 systematic review looking specifically at these navigation interventions, and it showed they did improve adherence to screening and attendance at primary care for chronic disease management. I'm just going to touch on a few examples of CHNs just to sort of highlight the range of roles that they have. So the largest rollout of community health workers worldwide is Brazil's family medicine program. The PSF, as it's known, started back in 1994, and it comprises community-based clinics which have a physician, a nurse, and up to 15, or actually even more, community health workers set up in a health centre. And it serves the poorest populations in Brazil, was where it started, but now it serves almost 2/3 of the Brazilian population, and there are over 250,000 community health workers now who are assigned to looking after 150 families or up to 750 individuals. But the key criteria used to select the community health workers, and this is one of the important factors, is they are residents in the community. They have a strong understanding of local geography and culture, and they're endorsed by the residents. And in this setting, the CHWs receive training in basic health concepts, healthy lifestyles, sanitary living conditions, and public health strategies. And the impact on that has been quite amazing. So they're looked on as one of the most comprehensive and cost-effective changes to a health system. And they're thought to have saved over 400,000 lives between 1996, the introduction of this program, and 2012, through improved access to screening, improved immunisation, and also early detection of disease, so particularly cardiovascular disease. They also found that infant mortality rates dropped by over 25% in areas that had access to this program compared to areas that didn't have access to the program. So really powerful. This model has recently been adapted in 2022 for use in the UK, and in a deprived area of South London, there's a trial of community health workers set up within a housing estate, and it's linked to general practices. And so the goal of this pilot was to improve access for health services for people living in this setting, and they've proven effective at providing counselling, mediating, building trust, relationships and rapport, helping with medication management, low-level social prescribing, and providing practical advice and motivation. Sorry, wrong one. Yeah. And there is evidence of identifying unmet medical need, A&E avoidance, suicide prevention, uncovering domestic violence or child neglect, all of which were otherwise unnoticed. Few studies have looked at the cost savings or the cost effectiveness of these interventions, and systematic reviews haven't found sufficient evidence. But this is one trial called the IMPACT trial, which is the Individualised Management of Patients with Action Plan. And in this trial in the USA, among low-income adults with multiple chronic health conditions, community health workers assessed social needs, provided everyone with a unique plan, and followed up with them with weekly communication. And it found that for every dollar spent on the CHW program, delivered $2.47 in terms of benefits to the health system. Now, Over a third of that reduction was due to reduced hospitalisation rates, which I think is important, and that's easy to measure. But the comments of the authors here was that it probably underestimates the sort of social return from this, because it's a bit harder to measure the cost benefit of keeping people healthy more so than it is to measure a saved hospital admission. So the benefits are likely to be higher than this, but it's one of the challenges for this area that we do need some stronger research methods to measure that sort of broader impact of these beyond secondary care prevention. I'm going to talk about Aboriginal health workers briefly. So, like within Australia, most primary healthcare is through general practice. In primary healthcare for First Nations people is driven by nearly 200 Aboriginal primary healthcare services operating around the country, nearly 150 Aboriginal community-controlled health organisations, federally funded, and just over 50 state-run Aboriginal medical services. But in both of these models, Aboriginal health workers are community health workers working within these services, and they are the most successfully integrated CHWs in Australia. It's one of the few positions, the Aboriginal health worker role is one of the few positions within our workforce that is exclusively occupied by First Nations people. And as such, they're instrumental in creating a culturally safe and responsive health system for First Nations people. They provide non-clinical support, so advocacy, liaison, health promotions in community settings and also hospital settings, and they really are facilitators for multidisciplinary care. They seek to provide whole of community, culturally safe, accessible primary care, and as members of the communities within their practice, Aboriginal health workers have an innate understanding of the strengths, the concerns and the lived experiences of the people they serve, and are uniquely positioned to be cultural brokers between the community and the health system. As with other community health worker or CHN roles, there's great variability in what Aboriginal health workers do, and that's based on community need, but studies have shown that they improve the uptake of preventative services, screening programs, and chronic disease management in their communities, and also facilitate culturally appropriate care, reducing communication gaps and ensuring referral linkage. And the note down the bottom there is they are an excellent example of multidisciplinary team cares. RACGP, we survey GPs every year saying, who's the most satisfied, and the GPs who are the most satisfied are the ones working in the multidisciplinary teams in Aboriginal and community-controlled health organisations. Now, I'm not going to give too much of this thunder away from my colleagues who are coming up, but so in Australia, some of our work in community health navigators has looked at the use of navigators to support transitions of care, so from hospital back into the community, and we're evaluating the impact of this support on health service outcomes, including hospital readmission. We also have two other studies which are looking at the use of bilingual health navigators in general practice settings, and you will see all the posters around the room and the growing work that we're looking at in that space, and some of my colleagues are going to speak about this soon. So bringing all of this together, you can see why we're quite hopeful that in a particularly complex health system, characterised by multiple funders, multiple delivery models, and multiple care systems, having a trusted advisor to support the most marginalised people to access care kind of makes sense, seems useful, seems desirable. But as I said, CHNs are not providing clinical care, they're trying to link people to the care they need. So they're not to replace other sort of complex social issues that do need other providers. As I say, it's this linkage role that's the crucial thing that they can do. Our systems communicate poorly and coordinate services inadequately, and we really need to improve that integration, particularly during care transfer, and that needs going to grow as our population ages and more people have chronic health conditions. Given the particular lack of communication and coordination in our system, I think there's a real need that unless we move towards greater technology or towards a single health system, the CHMs definitely are there to better integrate information. Like I mentioned before, like in our complex health system, often people are working in silos, and if you're working in the silos, you don't know what's happening in the other silos, whereas the community health navigators are trying to sort of go between them and are helpful at identifying the barriers that people are facing and can help address them. One other thing that the community health navigators hopefully can help with is they might be able to help people to identify and avoid the often unpredictable and even invisible costs that you face by navigating through our health system. And that cost, that is time, that is effort, but also financial costs as people move from one bit of the system to another. And it's promising to hope that with great care navigation, we'll be able to help our most vulnerable people and helping avoid them slipping through the cracks. So I've tried to cover a bit of the research, but what do we need to do now to help CHNs to grow? And I think Patricia and Susan have kind of highlighted the potential that we can do. We do have a promising emerging database, but that research agenda needs to expand, and we particularly need clearer guidance about how successful implementation might work. You've seen the range of roles that CHNs can have, but we need to draw that evidence tighter. We need to develop clearer guidelines for training and supervision and what that CHN role will look like. And really, we need to move from pilots and embedding CHNs more broadly. You can see how successful they are in the ARCHO setting, and there is a real need to broaden that. And then finally, we need to look at how we fund these CHN programs. Now, whether that be through bundled payment through the federal government, through collaborations with our primary health networks, or with the local health districts, or through new payments to primary care providers, or all of the above. And really, what I've tried to cover here is highlight that for all of us working in different parts of the health system, it seems complex, but when you look at it from a patient point of view, it's even more complex than any of us working in the system can recognise. And that is going to continue, and this lack of coordination is an ongoing problem. There is hope that with this increasing, there's potential of community health navigators to improve health outcomes, to improve patient experience and lead to cost savings, which we kind of called the triple goal of health improvement. And we're now at a point with the Strengthening Medicare Task Force where we have a reform agenda which is likely to lead to more team-based care, is looking at alternative funding models and also looking at how we create a multi-layered health workforce that meets the needs of our community.